right. Good evening, everyone. My name is Ria Suarez with the Cancer Support Community, and welcome to our webinar, Frankly Speaking About Cancer, Multiple Myeloma, Managing Long-Term Side Effects, which is hosted by the Cancer Support Community and sponsored by Onyx. A brief Q&A session will follow the formal presentation. If anyone should require technical assistance during the conference, please dial 1-866-229-3239 and hit option number 1. So before we start, I'd like to go over a few housekeeping items. As a reminder, today's call is being recorded and will be made available on our website at www.cancersupportcommunity.org/webinars. The format of today's webinar will be as follows. Our presenters will be featured first, and then we will begin the Q&A portion. Thank you to those of you who submitted questions prior to the webinar as part of the registration form. If you would like to ask additional questions, please feel free to type them into the Q&A box on the right of your screen. You can submit a question through the box at any time during the event. At the end of the webinar, you will be automatically redirected to the post-webinar survey. Please complete this survey as your input is invaluable to us. The survey will only take a few minutes. So to get us started, I'd like to give some background on the Cancer Support Community. We are an international nonprofit organization that provides social and emotional support to all people impacted by cancer. In 2009, the Wellness Community and Gilda's Club joined forces to become the Cancer Support Community. And through this network, we now have over 50 affiliates and 100 satellite locations that offer the highest quality of emotional and social support. Our mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. Here's just a couple of the resources that we have available. We have our Open to Options program, our Cancer Experience Registry, our Frankly Speaking About Cancer education series, and our Cancer Support Helpline. If you'd like additional information on any of these programs, please feel free to visit our website or call our helpline number listed there at 888-793-9355. So today, we will be discussing what multiple myeloma is, long-term side effects, the management of side effects, and follow-up care. It's now my pleasure to introduce our featured speakers, Jill Vanak and Kent Tygert. Jill Vanak is a board-certified acute care and advanced oncology nurse practitioner at Memorial Sloan-Kettering Cancer Center. She specializes in the care of patients with oncohematologic malignancies, specifically those patients whose treatment includes hematopoietic stem cell transplant. Dr. Vanak has been with Memorial Sloan-Kettering Cancer Center in a clinical and research role since 2003, beginning her career as a registered nurse at the bone marrow transplant inpatient unit. She has performed at multiple clinical levels and in 2007 took on the role of research nurse practitioner for the lymphoma service at MSK. Dr. Vanak continued her career at MSK in both a clinical and research role while completing a doctoral program in health policy and outcomes research at the University of Pennsylvania. Dr. Vanak's current role at MSK includes serving as a founding director of the Homebound Stem Cell Transplantation Program and as a clinical outcomes research consultant in the financial planning department. Kent Tygert is 56 years old and a high school graduate who worked in the family business installing, sanding, and finishing wood floors since he was 8. He is married with 3 children and 3 grandchildren. For 13 years, he has coached soccer and basketball for his children's teams and water skied with a competitive water ski show team, Cypress Gardens type style of skiing, for 14 years. He is a volunteer fireman for over 25 years, serving 7 of those years as an officer-in-chief. His greatest joys are camping and working on his 75 acres of property. Kent is currently living with multiple myeloma. Okay, at this time, I now turn the presentation over to Jill. Jill?
Hello, everyone. It is a pleasure that I get to speak to you today. I'm going to start with a brief overview of the disease itself, and then we will proceed into talking about long-term side effects and the management of such. So just to begin in brief, multiple myeloma, many of you are familiar with this, of course, is a cancer that affects the plasma cells. Plasma cells are a type of white blood cell found in the soft tissues of your bones or in your bone marrow. And plasma cells are a key part of your body's immune system as they make antibodies to help fight off infections. So with this type of cancer diagnosis, the plasma cells begin to multiply and grow out of control, beginning to crowd out healthy cells, including red cells, white cells, and other cells that work really to keep the bones strong. Over time, some of these plasma cells begin to spill out of the bone marrow, traveling to other parts of the body, and this can lead to some organ damage. The disease can weaken your immune system, causing anemia, kidney, and bone problems, all of which we will address today. Of note, it is not a bone cancer or a melanoma. People often get that confused. In terms of presentation of myeloma, kind of bucketed into two categories, either asymptomatic or smoldering myeloma, where the person will have no symptoms and the cells are very slow growing, or symptomatic myeloma, where the person will present with symptoms that can include one or any of the following, including bone pain, a fracture, some nerve damage, including numbness, weakness, kidney damage, etc. It is important to note that asymptomatic myeloma will become a symptomatic type of myeloma over the years, if not already. So in terms of staging, just again a brief overview. This is used in the clinical setting, of course, but myeloma is not staged in the same way as a breast cancer, a prostate cancer, a solid tumor, or any other disease state. And I just wanted to overview because you will hear this terminology. And your clinician will use two staging systems, one called the Dury-Salmon staging system, and one called the International Staging System, or ISS. Basically, it's just a quick categorization of your disease at presentation to help your clinicians and your team better understand your disease. And it's very helpful to talk with your physician, your nurse, etc., to learn more about the disease because, of course, each person's presentation is different. And in terms of treating multiple myeloma, again, we'll review this because your treatment can lead to long-term side effects as well as the disease itself. So goals of treatment. There are many goals of treatment. Among them include prolonging survival, managing symptoms and optimizing quality of life to the highest degree possible, and maintaining function. Since there aren't any cures at this point in time for myeloma, although science is absolutely extending life years, it is treated now like a chronic disease, and it is managed as such. So in terms of treatment considerations, there are a number of medications and treatment regimens that are used for this disease, and there are many, many more in the pipeline. Clinical trials are always an option and always ongoing, not only for new drugs that are prone to come onto the market, but also for existing standard treatments. There can be clinical trials to see if one standard treatment does eclipse another standard treatment. There are many phases in this disease. And it does, of course, help to discuss a long-term plan with your physician and your providers to help determine which drugs you're going to use over the course of your illness, when, and why. So, again, a number of treatment options for this disease, including what we call conventional or standard chemotherapy, targeted therapies, steroids, frontline or induction agents, and those include thalidomide, lenalidomide, otherwise known as Revlimid, and bortezomib, otherwise known as Velcade, which many of you are likely familiar with. Treatment can also include a bone marrow or stem cell transplant, can include radiation therapy, and supportive therapy, which we will discuss. So in terms of supportive treatment, this is something that is always going to be on deck, for lack of a better word, with any of the treatments that we described prior. Supportive therapy is used to allow your body to recover, and it's given in tandem. I like to describe multiple myeloma as a completely non-linear disease. It really is difficult to say that we're going to start with treatment A. If treatment A doesn't work, we're going to go to B. If B doesn't work, we're going to go to C. In the treatment of multiple myeloma, there's a lot of gray area, for lack of a better word, and treatment is often dependent on the patient as well as the disease, of course, in terms of, are you experiencing side effects to the drug that you're on? What's your age, your quality of life, your comorbidities? There's a lot of gray area, and it's very nonlinear. So in terms of supportive treatment, you will likely be exposed to things such as growth factors. So growth factors, or growth colony stimulating factors, are injections that are often given after chemotherapy to help raise your white blood cell count. They're used to treat and prevent infection, to treat and prevent anemia, which again is caused by the disease as well as the treatment that you're getting. Units of blood, or packed red blood cells, which is PRBC. Other treatments that can be used include erythropoietin, or another brand name of that is Procrit. Oftentimes we can use a radiation technique, radiotherapy, or even kyphoplasty. If your disease has affected your vertebrae, they can actually do construction and kind of implant cement, basically, in between your vertebrae to help ease that pain and discomfort. And a common treatment is biphosphonates. So biphosphonates are medicines that are used in the treatment of myeloma bone disease. They're used in conjunction with other therapy. Bisphosphonates have been shown to help slow the advancement of bone disease, decrease bone pain, reduce fractures. So long-term side effects. Now, please remember this list is not comprehensive by any stretch of the means. Your long-term side effects are, again, going to depend on your disease, your unique presentation, and your status as a person, how you're reacting to different types of drugs, and your health status prior to that cancer diagnosis. But the big buckets for these long-term side effects include fatigue, bone pain, renal or kidney dysfunction, myelosuppression, which is just a suppression of all of your blood cell counts, your white counts, your red counts, your platelets, which can then lead to infection, peripheral neuropathy, and sexual dysfunction. So we'll first start with an overview of fatigue, and by far, this seems to be the most common, most prevalent symptom that every person with this disease faces. Causes are multifactorial. The disease itself, remembering your blood counts, your red cell count especially, is being lower to the point where you have less hemoglobin and less oxygen circulating in your body. You're going to be tired. Not only can the disease do that, but a lot of the treatments that we prescribe do that. Other causes can include comorbidities. For example, if you had some cardiac issues and some heart malfunction prior to the diagnosis, that can lead into this. Again, like we talked about side effects from treatment, and if you're experiencing pain, that can lead to fatigue. Your fatigue level is increased from different combinations of treatments. It can be increased if you have an advanced stage cancer, and it is commonly increased in an older patient population. Signs and symptoms of fatigue. Again, I'm sure I don't need to express this to anyone who's experienced this, but it can present in different ways. Lack of energy, difficulty sleeping, which you wouldn't necessarily assume right away would be fatigue, but that is a presentation. In turn, it can present as difficulty waking up or just getting the gusto to get up in the morning. It can present as anxiety or depression, even muscle pain. You can become breathless after activities of daily living. So that is a very clinical, common word, ADLs, activities of daily living. What that really means is doing your normal day, getting up, brushing your teeth, cooking, tying your shoes, those kinds of activities. Can present as lack of concentration, potentially even apathy, loss of interest, or even negative feelings about the process, life in general, etc. So how to manage fatigue? This is the million-dollar question, and if we knew how to do this, this would be the answer to a lot of problems. But there are some treatments that, can be prescribed. So medication, in some instances, can help. And when we say medication, this is not common to prescribe for fatigue, and the reason is we essentially know what's causing the fatigue. We know that it's your disease. We know that it's your treatment. And it's just a process of once you get past those milestones into a remission status or into a lull between treatment, that fatigue usually ebbs a little bit. However, there are medications such as psychostimulants. Common names are modafinil, even Ritalin, some antidepressants that can be prescribed. What also helps with fatigue is treatment of anemia. Remember, one of the major causes of fatigue is a low hemoglobin level, which in turn causes lower oxygenation and lower oxygen circulation throughout the body. So a unit of packed red blood cells, maybe some erythropoietin like we talked about earlier, that could assist in managing your fatigue. Again, might seem counterintuitive, but exercise has been shown in large-scale studies to help. So some low-impact exercise, things along those lines. Taking short naps or rest breaks throughout the day. Even sleep counseling. There are experts in this area, but even if you get into a routine to really try and go to sleep and wake up at the same time every day, that's been shown to be helpful. Nutrition and diet, just foods that are very energy-packed. That sugar high is not a myth. That can really bring you down, and just to have that glycemic index kind of slow and steady can help with fatigue. It has also helped people to keep a fatigue diary, noting the points throughout the day that you experience this fatigue or where you're especially perky with a lot of energy. And finally, a support group talking about fatigue and seeing how other people manage it has been shown to be effective. So the next big symptom is bone disease. And bone disease, unfortunately, is a hallmark of multiple myeloma. So bone disease is caused by defects in the balance between bone formation and bone resorption. And depending on which study you're reviewing, about 80 to 90% of patients will have some type of osteoporotic or osteolytic bone lesions at some time during the course of the disease. And consequences of bone destruction can include fracturing, especially of your long bones. When you think about your femur or your humerus, those can be common sites. Vertebral collapse, what we talked about before with the treatment potentially being kyphoplasty or having that cement kind of build up and support the vertebra. And common sites for bone disease basically looking at this list, it looks like everything basically is common. But to be honest with you, it really does present most often in those big bone areas. A lot of times we will see this disease present, like we said, in the long bones, in the femur or in the humerus. Spinal cord is a site of presentation. The skull is less common. I would say that the spinal cord and long bones are the most common sites of disease. So bone disease is a major effect or complication of this disease. And again, as we talked about, the bone destruction itself can lead to complications, including fractures like we talked about. And these are fractures that I didn't bump into anything, I didn't fall. They can often occur spontaneously or with the slightest bit of pressure. And again, it's because of the disease. Can lead to spinal cord compression. It can lead to some nerve damage and neurologic changes, severe pain, again, due to this bone invasion, and it can also cause your calcium levels to increase just due to that bone breakdown, and basically that calcium can kind of spill out into the blood. So in terms of prognostic implications, or what we're looking for clinically, the greater number of bone lesions one has does correlate with a poorer prognosis. And the other major issue that we obviously try to combat is that complications can occur with bone invasion, which we've outlined a few of them above. And just to have as a fact is that despite continued treatment, some skeletal events can progress, meaning, unfortunately, some of the treatments that we give for the disease itself don't really do much to affect the skeletal areas if that bone has already been invaded. In terms of consequences of bone disease, what we are looking to prevent and what we are looking to treat, of course. We want to make sure functional mobility is kept at its highest level. We're looking for pain. We're looking to see if it's having an impact on activities of daily living, employment status, things along those lines. In terms of neurologic changes, and this is often due to that spinal cord invasion, if that is affected, of course, we want to ensure that we're always on the lookout for these bony lytic lesions to avoid paralysis, to avoid paresthesia. Paresthesia is just a fancy word for numbness and tingling. People often can describe paresthesia with peripheral neuropathy, which we will get to, but when your foot falls asleep, but to the severest level. And again, we know through studies and research that bone disease can have a psychological impact in terms of depression, body image issues, things along those lines. So in summary, bone disease is related to multiple myeloma. And the way we manage bone disease or try to keep on top of it, of course, is by treating the underlying disease. So common treatments that we've spoken about do include these frontline or also known as novel agents, even though they have been on the market for years. Velcade, thalidomide, Revlimid, they're just in different classes of drugs. Steroids, radiation therapy can be used, especially if there's a single lesion of disease. Surgery, when we talk about surgery, that really refers to the kyphoplasty procedure that we've talked about in terms of that cement. And bisphosphonates, as we spoke about before, they are a very important class of drug in the treatment of multiple myeloma and are in fact basically standard fare. We give them in conjunction with all treatments because, again, they've been shown to assist in stopping the advancement of bone disease and things along those lines. So in terms of recommendations for follow-up care, or just what you should really be proactive about and tell your clinician about if you feel that any of these are decreasing. We want to make sure that your mobility is intact, that you're able to take walks, that you're able to do what you were formerly able to do, of course with the caveat that fatigue might be hindering this. We want you to be able to perform exercise, whether that be light, brisk walks. Dietary recommendations are something that absolutely will be a discussion with your provider. Many centers have nutritionists, really just to keep you as healthy as possible. Routine assessment of bone disease. So this is going to include your routine blood work, and it's also going to include imaging. There's such a thing as a skeletal survey, which is basically an x-ray of your entire body, and that's often done at routine intervals for people with multiple myeloma, just to assess if any disease is present. So in terms of oral care, almost every treatment we've talked about, but specifically radiation, surgery, and the use of the bisphosphonates can cause problems with the oral cavity. So this is especially important for you to be aware of as you go through treatment and recovery. Some common symptoms are going to include dry mouth. It can include changes in your teeth, in your actual dental status. You might have been a person who never had cavities in their life, but again, you're more susceptible to sources of infection and things along those lines. And the bisphosphonates are notorious, although they aid in stopping the advancement of bone disease and are absolutely a necessity in the treatment of multiple myeloma, they do have side effects of their own. And one of those side effects that is severe and not common is osteonecrosis, or just inflammation and some breakdown of the jaw area. So, of course, that's something that we watch like a hawk and that you need to be aware of as well, just the importance of oral hygiene in this setting. You always want to look for infections in the mouth, any painful mouth or gums, any loss or change in sensation. And again, as part of your routine care, dental care should be a part of that plan of care. So the next big symptom, if you will, is kidney dysfunction. And this, of course, like all of these other symptoms, could and does warrant an entire presentation on its own. But this is just meant to be a brief overview, of course. And again, I should have reviewed this earlier, and I apologize that it's halfway through. But these symptoms, yes, they're common. It does not mean that you are going to get these symptoms in conjunction with one another. You could very well have a myeloma diagnosis without severe kidney dysfunction, without bone pain, etc. But again, since these are common, we will review them. So kidney dysfunction, again, a very common clinical feature of that symptomatic myeloma. The causes, as in everything else, the disease itself. There are specific types of multiple myeloma, which are more commonly those that cause kidney function, especially those involving light chains, and the deposition or depositing of these light chains in the kidney tubules can lead to kidney dysfunction. This overproduction of calcium from bone breakdown, etc., can lead to kidney dysfunction, and overproduction of uric acid, another electrolyte. So renal complications. About 20 to 60% of patients do present with some form of a renal complication, and I know these statistics are very broad. We're giving you a very big range. So again, this is just an analysis of the research that is available and in the literature. So that range is going to be large. Again, you can present, or basically clinically what we would look for with renal complications. Often patients present with an elevated serum creatinine level. So basically that is a lab value. We can tell that you have an elevated creatinine level from a lab test called a basic metabolic panel, which is going to be a part of your routine experience when seeing the physician. he or she will be able to tell you that number just about every time you go to the doctor for a visit. Anemia, fatigue, we're always going to be on the lookout. It commonly presents with some electrolyte imbalances. Your potassium, your sodium, your calcium might be off, and that's what we're going to look for. Again, we can find that in the blood work. And light chain proteinuria. This is found through urine samples and urinalysis testing, which will, again, be a part of your routine care. Why do we care about the proteinuria or the buildup of protein? It could lead to end-stage renal disease if it's not managed. So that is something that we always test for. So in terms of recommendations for the treatment of renal complications, this is absolutely going to be done in conjunction with your provider. However, a huge thing that you can do for yourselves at home, wherever you are, hydration. Hydration is a must to just help and assist the body in clearing the kidneys. You need to avoid a class of drugs commonly known as NSAIDs, or non-steroidal anti-inflammatory drugs. And again, your provider will review this at length. But NSAIDs, common ones include Motrin, ibuprofen, Aleve. Tylenol is not an NSAID. But basically, if these drugs are used at a very high rate, they can lead to kidney complications. Of course, what's going to assist in managing that type of complication is compliance with clinic appointments. Again, we draw a number of blood tests and lab work just to ensure that those kidneys are working properly. So again, you want to keep those appointments so that we can absolutely keep an eye on trends in your lab values and in your blood work. If the kidney damage or the kidney complications are severe, you'll often hear your provider say that they want a non-contrast scan. If you have to go for diagnostic tests like a CAT scan or an MRI, a lot of times, depending on what we're looking for, we can use a contrast dye or we cannot use a contrast dye. The issue with contrast dye is that it's very toxic to the kidneys. So you might hear those terms thrown around in that they would like you to get a non-contrast CT, and that's basically why that's being done, so as to not further damage any kidney effect. And again, the other thing, which is difficult to avoid, but we want to avoid infection. Anything that's going to suppress that immune system makes you prone to infection, and again, we would like to try to avoid that. So myelosuppression. Myelosuppression is basically a suppression of your bone marrow. And your bone marrow produces the cells in your body. Red blood cells, white blood cells, platelets. If you think about your bone marrow, it's basically the breeding ground for every type of cell that then circulates throughout your body. So marrow is commonly found in the inside of those long bones that we talked about before. People often think of it as your hip bone, but marrow is within your sternum, within your femur. Those are common sites. So in terms of myelosuppression, what does myelosuppression lead to and why do we care about it? It leads to all the things that we've been talking about. Suppression of your red blood cell counts, which leads to anemia, which can cause fatigue, shortness of breath, weakness. The suppression of white blood counts can lead to neutropenia. And when your white blood cell count is decreased, this increases your risk of all types of infections, bacterial, fungal, and viral. In addition, suppression can lead to that suppression of your platelet count, and that's known as thrombocytopenia. And when your platelets are low, you're going to bruise more easily, you're going to bleed more easily because that clotting mechanism has decreased. And as a preface, or just as a reminder rather, again, myelosuppression is caused by the disease itself, but is also caused by a number of the treatments that we provide. So just a brief table on myelosuppression rates. I threw this in as an example. So these are very common drugs in the treatment of multiple myeloma. Thalidomide and dexamethasone is a type of steroid commonly given with thalidomide. Lenalidomide is otherwise known as Revlimid, which might be a more familiar term, commonly given with dexamethasone, that steroid. And bortezomib is commonly known as Velcade. So I don't have all of the treatments listed here, but these are common ones. And again, this is from a research study, and it just shows the risk of what we would call severe myelosuppression. So again, you can see numbers that thalidomide in 16% of patients, it caused anemia. In 13%, it caused neutropenia or low white blood cell counts. And really the goal of this slide is to show you that the treatment can cause these effects. And remember, often these treatments are used together. So you can even double these rates. It's something that we're always aware of and that we're always on the lookout for. We want to prevent infection and we want to try and boost your counts as best we can. So in terms of anemia, again, the disease and the treatment can cause blood counts to lower. What do we want to do? What are our goals as providers? Number one, the biggest treatment of anemia is to treat the underlying disease. We want to decrease your level of fatigue. We would like to decrease your need for blood transfusions through blood cells. However, that is absolutely an option and very standard in the treatment of anemia. Again, our rule of thumb is to treat the person and not the number. So to treat the person and not the number. Again, there's going to be a standard for everyone. Not necessarily going to walk into the physician's office and say, my hemoglobin's 8, I need a unit of packed red blood cells. If you're feeling okay, no fatigue, etc., that threshold could be lower. In terms of treating this side effect, what you can do to be proactive and what we're always looking for, report shortness of breath. If we don't hear about it from you, we won't know. It's very important to report that. It's always an excellent idea for you personally to be aware of your blood counts, be aware of your hemoglobin levels. Like anything else, once you start following the trends, you're going to know what's quote-unquote normal for you and kind of where your sweet spot is, for lack of a better word. You're going to know that, okay, with a hemoglobin of 9, I feel okay. With a hemoglobin of 7, I absolutely am out for the count. A common question that we get, can I boost my red blood cell levels by eating liver, by eating proteins? That answer is no. One person would not be able to it's not humanly possible to consume that amount of liver that would actually have an effect on your red blood cell counts. The caveat to that, though, is it's absolutely vital to have a good, nutritious diet. That is for sure. In terms of keeping you healthy. But it's a common question and one that, definitely won't really affect that level. So the next symptom that we spoke about, infection or neutropenia. Neutropenia is a definition of low white blood cell counts. That in turn commonly leads to infection. So people with multiple myeloma commonly get recurrent infections because we've lowered your white blood cell count, but we've also reduced your immunoglobulin level. So immunoglobulins are antibodies within your body that help to prevent disease and fight off foreign substances and foreign infections. Those lower due to the disease and due to treatment. So again, treatment goals. We want to treat the disease. We're commonly going to use growth factors. You might hear about them in regards to Neupogen or growth colony stimulating factor, GCSF. They are subcutaneous injections or a shot that goes right under the skin that are often given after chemotherapy because they help elevate the white blood cell counts during that time when the chemo is really hitting your body the hardest. And again, prevention of infection with the use of oral antibiotics or even IV antibiotics if needed, and prophylactic medication. Commonly, when you are undergoing treatment in the form of chemotherapy or things along those lines, you will be placed on an oral antibiotic. Things that you can do to decrease your risk of infection. Absolutely, without a doubt, report symptoms. The big symptom to report that you will be reminded of over and over again, if you have a fever, especially during a treatment process, you absolutely need to notify your physician and your provider team, even overnight. It should not go unreported because that is a key sign of infection. You definitely want to keep all of your clinic appointments because, again, we're going to be drawing blood to look at those white blood cell levels, to look at the immunoglobulin levels. If okayed by your provider, you absolutely want to get an annual flu shot. Again, rule of thumb is you should not get any injections during the period of your cancer diagnosis and treatment without speaking to your oncologist and getting the okay, but absolutely that would be recommended. And you want to have discussions with your medical team even about your hobbies and things you like to do. When your counts are low, for example, we would tell you to avoid gardening. Oftentimes there's fungus, and you could get an infection of the lungs known as aspergillus. So gardening and things like that can increase that risk. So you just want to have frank, open conversations with your team to kind of know the rules of thumb while you're undergoing treatment and recovering from treatment. So bleeding and bruising. So this is thrombocytopenia, or rather low platelet counts, which is known as thrombocytopenia, leads to bleeding and bruising. Again, both the disease and the treatment cause these counts to lower. Goals. We want to keep the platelet count at a specific threshold. It is not common practice, nor will it ever be done, to let your platelet counts fall below 10,000. A normal platelet count, just for reference, can be between 150,000 to 400,000. Usually, we keep your platelet count above the 20,000 mark. If you're having any other sources of bleeding or any other issues or comorbidities, we keep it above 50,000. You want to avoid the use of anticoagulants, meaning aspirin, things that will thin your blood to a large degree. And again, these are conversations that you're going to have with your healthcare team. But you should expect this if your platelet count drops, that they will ask you to avoid aspirin and things along those lines for that period of time. In addition to other recommendations, you want to avoid the overuse of those NSAIDs, that class of drug known otherwise as Motrin or Aleve or ibuprofen. And again, 1 or 2 routine common doses will not affect your system. We're really talking about heavy use of things along those lines, but it's common practice just really to avoid that drug class if you can. Other things that you can do if your platelet count does start to lower, which it will after treatment and due to the disease, you definitely want to speak to your providers. You want to avoid contact sports. You want to avoid any high-risk activities that would cause that bleeding and bruising to occur. So in terms of management, we've spoken about these tips, but how do we manage this? Myelosuppression management. So this happens to every person with multiple myeloma. So this is a key talking point for your nursing staff and for your providers. How we manage it, we monitor it. So every time you come in for an appointment, basically, we're going to draw what we call a complete blood count, and that will allow us to see your white count, your hemoglobin level, your red cell count, and your platelet level. So we're going to keep trends. Also, education, education, education. We really want you to be proactive and aware of what's going on in your body, what you can do to manage these things, and basically how you can feel your best even while you're undergoing this process. So we spoke a little bit about how we monitor this. We can use Neupogen, or that growth colony stimulating factor. This is common practice to use after treatment. If your counts are not responding and they really do hit a low point, oftentimes physicians will dose reduce your treatment. That is not unheard of, and that can be very common practice, just to lower the dose. You can and will likely have some packed red blood cell or platelet transfusions, both of which can give you a bump in those counts. Or if very severe and you have a very high-grade episode of thrombocytopenia, neutropenia, etc., we can discontinue treatment and potentially give you a washout or recovery period, and then maybe try something that's less toxic or less myelosuppressive. Again, these are absolute conversations which you will have with your team. Peripheral neuropathy is another very common side effect that we see in patients with multiple myeloma. Again, as in everything else, it can be caused by the disease, but often this is seen and caused by treatments that we give. So, signs and symptoms of peripheral neuropathy, that paresthesia or that numbness and tingling like we talked about. And the numbness and tingling is going to occur in the feet and in the hands primarily, in those extremities. It can present as a burning pain, almost like a plantar fasciitis, some people describe it as, or even a muscle weakness. And the peripheral neuropathy, in terms of a definition, it's damage of peripheral nerves. It's damage of those nerve endings from treatment. So again, the disease and treatment place people at risk. Two drugs that are notorious for causing peripheral neuropathy include thalidomide and bortezomib or Velcade. Again, this is not to say that every person who has these drugs will experience this side effect. The other thing to note is that this side effect occurs at varying degrees. Some people have continual numbness and tingling. Some people have peripheral neuropathy that's severe to the point where they now have to use a cane. Some people feel it intermittently as if their foot falls asleep, and other people say, it doesn't really affect me. I feel numbness every now and then, and it goes away shortly. It's something that's absolutely difficult to tell, and it's unique to every person. In terms of management of this, education is key. And for you, that means absolutely staying on top of your providers, letting them know when they run through the checklist of how do you feel. Well, I'm having numbness and tingling. I'm having such and such. It is absolutely a synergistic relationship. We need to hear from you, and of course, we need to then educate about that. So be proactive in that and just absolutely let them know what's going on with you. Continuous management. Non-pharmacologic management, which I'll go over, and pharmacologic management or medications. So basic rules of thumb. If you're having this neuropathy, you want to be careful when handling sharp objects, knives, utensils, etc. Avoid falling. This can be difficult to do, of course, but really if you're experiencing it, you want to walk slowly, hold on to handrails. Oftentimes we have patients put no-slip bath mats in the tub or shower, or remove area rugs where you can easily slip. Important to protect your feet. You want to wear tennis shoes or other footwear with rubber soles. You want to use a thermometer and gloves instead of your bare hand, meaning if you're handling hot water, hot anything, you're not going to have that same sensation that you had before potentially if you have this neuropathy. You're not going to be as attuned to temperature changes. So you want to be extra careful. And you want to allow yourself time to rest. In terms of non-medication or non-pharmacologic ways to handle it, a gentle massage of affected areas with cocoa butter has been shown in some studies to be helpful. Absolutely, if you are experiencing this, a physician can write a prescription for a home health referral. Someone can come in and look at the safety of the home and tell you, okay, this should be removed, that can stay. If you need assistance with activities, and there are many referrals within the hospital for pain management, for neurology, maybe some physical therapy can assist with this. Medications can assist as well. And again, the research on this is quite diverse. There is no medication, unfortunately, that exists that absolutely cures peripheral neuropathy. The guidelines are, for the most part, the neuropathy can improve years and years out of treatment. But what is shown is once you have that neuropathy, it usually lingers and is usually something that stays. It can wax and wane and decrease over time, but it is not something in the same class as a fatigue or as an anemia that will improve the farther away you get from treatment. In terms of medications, things that are commonly prescribed can include B-complex vitamins, B1, B12, folic acid. For more severe types of peripheral neuropathy, tricyclic antidepressants, so things that you would be aware of as antidepressants actually assist with that nerve pain and those nerve endings. These can include Neurontin, Lyrica, Cymbalta. And another commonly prescribed medication is a lidoderm patch. And basically, this is a patch that secretes this medication that can help numb that area or really kind of assist with pain management. If you are having peripheral neuropathy, that is absolutely a side effect that we want to know about because it can affect your treatment. We'll absolutely reduce the dose of your medication if it's becoming severe, or we can schedule delays, or we can discontinue your treatment altogether. If you had neuropathy that was getting to a higher grade, we would absolutely not continue your current course of treatment if it was leading to more severe neuropathy. Pain management. Pain can be caused by damage of the nerves from chemotherapy. And the pain we're talking about here is really leading off of the peripheral neuropathy, but of course you can have pain related to bone disease, related to a number of issues. So management of pain can include medication, it can include physical therapy, acupuncture, it can include complementary alternative medicine, relaxation technique, it can even include nerve blocks if it's severe. You definitely want to speak with your doctor about pain. And the best things that you can do when you go into your clinic appointment is really to be prepared to talk about it. We're going to ask you, on a scale of 0 to 10, how severe is your pain? You want to be able to describe what the pain feels like. Use the most descriptive words you can. Is it sharp? Is it dull? Is it throbbing? Is it steady? You want to be able to, of course, if possible, point out the exact places it hurts, either on your body or on a drawing. Again, if you can keep a diary, when do you feel that pain? When does it start? How long does it last? Does it get better or worse, or it always stays the same? You want to be able to describe how your pain affects your daily life. Does it stop you from working? Do you have to rest all day? You want to make a list of any medications you're taking for pain, and definitely if any of those medications have side effects. A lot of opioids, a very common side effect is constipation or issues with your bowel. And again, keep a record of your pain. All of those things will help your provider in prescribing the best type of pain medication. And again, a lot of hospitals and institutions have pain management teams that specifically are attuned to management of pain and are experts in this area. So do not be afraid to ask for referrals or inquire about that. So in terms of sexual dysfunction, It's characterized by both psychological and physiological changes that negatively impact sexuality. That is the definition. It affects 31 to 43% of men and women in the United States, and that number is of the entire U.S. population, not those with multiple myeloma. A myth is that it is part of the normal aging process. This is not true. It truly is a separate diagnosis. And it can result as a consequence of many things. It can result as a consequence of treatment. If there is that nerve damage and that neuropathy, some comorbidities can be prognostically indicative: fatigue and depression and anxiety. So, in terms of what is seen, sexual dysfunction can run the gamut. It is often equated to erectile dysfunction, and that is not the case. It can be worrying about intimacy after treatment, struggling with body image. It can be coping with not being able to have sexual intercourse as you did before. Some men can no longer get or keep an erection after treatment for, let's say, a prostate cancer or cancer of the testes. Some women find it harder or even painful to have sexual intercourse after treatment. Sometimes there is no clear cause or nothing we can attribute it to. Other things that we don't necessarily think about when we hear the word sexual dysfunction. A lot of times, treatment for cancers, including multiple myeloma, cause early menopause for women. So for younger women with a cancer diagnosis who are undergoing treatment, it will throw you into an early menopause, and you will absolutely experience hot flashes and true symptoms that can absolutely affect quality of life. Vaginal dryness is another common issue. Some muscle weakness. If you're younger, concerns about having children. Again, there are many types of sexual dysfunction disorders, and these can include sexual pain, sexual arousal disorder, sexual desire disorder, or decreased libido, and that is very common from treatment. In terms of the definition, it's important to note that it's only considered sexual dysfunction only if it has a negative effect on your life and on your relationships. So the reason for bringing this up is that this is often placed on the back burner. Treatment of the disease becomes a priority. Your mind is elsewhere. The provider's mind is elsewhere. But this is absolutely a real symptom, and it absolutely affects quality of life, and it is something that you should bring up with your clinical team if there are any issues, and to be honest, a good clinical team should bring up with you. So do not hesitate to speak about this because it's important. Providers need to know, and there absolutely are things that can be done. Again, a number of hospitals have fertility specialists on staff. We can refer you to a fertility specialist, and there are sexual health counselors on staff in a number of hospitals. There are medications, lubricants. It runs the gamut of things that can be done. So please do not suffer in silence for something that you might think, oh, that's not important. No one needs to know about that. We really need to change the culture so that we can start having frank discussions about this just like any other symptom. So general strategies for wellness. Again, these are the tried and true things that we tell everyone, but they do make a difference. If you're a smoker, you need to quit. We absolutely have smoking cessation problems if that's an issue. During treatment, during this process, you want to cut down on alcohol intake. That's not to say that you can't have any alcohol, but you need to talk to your providers. Eating well. Upping the nutritional value of those foods is highly important. We want you to exercise. We want you to stay active, all while avoiding falls if you are high risk. Exercise can help decrease muscle atrophy, things along those lines. In terms of follow-up care, these these are things that you should expect. These will be routine parts of your clinic visits. Again, it's dependent on the type of cancer and the type of treatment you had, along with your overall health. But your team should review your medical history. You're going to get a physical examination. A part of living with multiple myeloma is getting these repeat diagnostic tests. Unfortunately, because myeloma invades the marrow, you're going to have routine bone marrow biopsies and aspirates in which you lie on the table, go in with a needle through your hip bone and pull out some tissue. That's going to be routine. CT scans can be a routine part of that testing, those skeletal surveys. Just know that that's going to be on a routine level. Blood tests like we talked about, and again, a key, always inform any new doctors about your cancer history, including a new dentist, anyone along those lines. So information is needed in order to manage your care. Really, if I can stress anything to you, it is please to be open with your provider and your team. And if you feel you can't be open with your team, they are not the right team. It's important to remember that the onset of certain symptoms does not necessarily mean that the cancer is quote-unquote back or it's progressed. I think it's important to remember that you're going to get aches and pains and symptoms just like anyone else, in addition to those things that are either caused by the disease or caused by treatment. It's just important. It's very difficult mentally for people with this diagnosis to kind of go through this and not jump to, okay, the cancer's back. But remember, that's not always the case. However, you absolutely need to keep your team aware. Any new symptoms, any pain, physical problems, any new medicines you're taking, and that includes vitamins, herbs, over-the-counter things. A lot of people forget that these can have real interactions with other drugs that we prescribe, so it's very important to know your full medication list. Any changes in your family's history, and be open about things that you want more education on. And in summary, optimal patient care, if we can even define that. Basically, adhering to treatment, but adhering to it safely. If you're having symptoms, we're not going to continue treatment past a safe boundary. As we talked about before, myeloma drugs there are a plethora of drugs coming through the pipeline, and we've made such scientific advancements. It's a gray zone. There are absolutely other therapies that can be given. We want to make sure your quality of life is enhanced. We want to prevent complications. Effective management has to include you, the person with the disease, and your caregiver. That's the way it's going to work. It's a team effort. Careful monitoring and assessment. We want to prevent and be aware of symptoms as soon as possible, and of course provide appropriate, quick, and effective interventions. And as always, proper health maintenance will contribute towards longer survival and a better quality of life. And in terms of resources, if your hospital has these resources, if they don't, there is a large community, of course, first and foremost, the cancer support community. They offer online support, they offer telephone calls, financial aid support, social work support, you name it, they have it, and it's an excellent resource. There are patient navigation services. Many hospitals have nurse navigators or patient navigators, someone to help you through the system. And then financial resources at a number of different places, including Cancer Financial Assistance Coalition, the Health Well Foundation, etc. Again, just a list of resources, and these will be posted for you. It's important to know about the American Cancer Society, American Society of Hematology, Multiple Myeloma Research Foundation. Do not hesitate to reach out because they can have absolutely wonderful programs, and they do. And hospitals use their material, their education services, their hotlines all the time. And I will toss it over now to Ken.
All right, great, thanks. Kent, we will Now turn the presentation over to you. Kent will be sharing some of his experience with living with multiple myeloma. So Kent? Kent, are you there? Okay. All right. So we will move on to the question and answer session. I'll try to get Kent on the line here. But again, you can post any question through our Q&A box, which is on the right. So just give me a few minutes while I pull for some questions. All right, Jill, the first question is for you.
Okay.
So what are the long-term health effects of taking regular monthly chemotherapy drugs over a period of 3 years? Are extended chemo holidays effective in rebuilding basic health and balanced blood work?
So that is an excellent question, and of course I do not mean to be obtuse, but it really is going to be unique to your situation. In terms of the effect of chemotherapy, it is a systemic treatment, which you well know, meaning it not only affects those myeloma cells or those malignant plasma cells, but it will infect healthy normal cells as well. So absolutely, if you're getting conventional chemotherapy, your cells are going to be affected. You're going to have myelosuppression. You're going to be more at risk for infection. Your body is going to feel that hit over and over again. And the key to that is supportive treatment, potentially transfusions, things that we talked about. In terms of those recovery periods, it really is dependent on your disease status and where you are. A lot of times, if you'll get that big hit and then you will have a remission period or a partial remission period, you can speak to your provider, and part of that therapy might be what we call maintenance therapy, where you're prescribed maybe one of those novel induction agents like a thalidomide or a Revlimid to basically keep your disease at bay. The issue with multiple myeloma, which again you well know, is that it is a chronic condition. Unlike other cancers, it's not linear. Other cancers, we give you a big hit of chemo, your counts drop, we recover you, you're in remission, no treatment, no treatment, no treatment until you relapse, or if you relapse. Multiple myeloma, unfortunately, is not like that. It is absolutely common to be on some type of treatment throughout the course of the disease and not to have that recovery period. It is really unique to your stage, your presentation, and the actual treatments that you're getting, though. So it's an excellent question, and I hope I was able to provide some insight into that, although it is difficult without knowing the exact treatment in that regimen.
Okay, great. Thanks, Jill. We have another question. For people in remission, what do we need to do to keep it that way?
So another excellent question. In terms of remission, it's something that what you can do is to be proactive. You absolutely need to continue with your routine visits, your routine monitoring, which I'm sure is something that is ingrained and something that, of course, you are doing. Really, what you can do is keep yourself healthy as possible. Your diet, nutrition status, exercise, start building up those muscles. Those are true things that you can do in order to make yourself as healthy as possible and to keep that prolonged remission. Unfortunately, in terms of a remission, it is difficult to know the length of it because this is a chronic condition. there's going to eventually be relapse, but of course you're going to want to hold on to that remission as long as possible. And really what you can do is just what we spoke about, keeping yourself healthy, keeping yourself free from infection, getting that annual flu shot, things along those lines. Health maintenance are the keys to you doing what you can do to really continue with that.
Okay, great. Thank you. So what happens first when the kidneys start to be affected by myeloma? What is the progression timeline from that point? What can one do to slow down the damage, if anything?
So with that being said, again, another question that I hope I am not too broad in answering, but it really is dependent, number one, on the type of myeloma that you have, and then subsequent treatments. So with that being said, a number of people present with kidney damage when they're diagnosed with myeloma. And that commonly can occur if you have a specific type of myeloma known as light chain disease, because what happens, as that slide had said earlier, is that what can happen in this disease is that there is a deposition of light chains in those kidney tubules, and it really can start to affect that organ and start to affect the kidney function. So again, it is difficult to pinpoint, but a number of people can present with kidney damage. To what degree that is, it remains to be determined based on your creatinine levels and your creatinine clearance and different tests that we're going to do during your workup, but to present with some form of that damage. In terms of what you can do, the answer is going to be along the same lines as prior in terms of hydration is key, and really, really keeping up on your blood count trends. The biggest number that we're going to be watching for is your creatinine. So creatinine is a large marker for us of your kidney function. And a normal creatinine, just for reference, is about 0.6 to about 1.2. Not to say that you cannot live with a kidney function trending in the high 2s, trending in the 3s, but that's our goal, to get that down as close to normal as possible. So that's our first marker. So what you can do, come in for your regular appointments. Hydrate, hydrate, hydrate. Just be cognizant of what is going on. And in terms of avoiding those Motrin medications, ibuprofen, that NSAID class. Those are really the key elements, and really just the management of your disease is what's going to help with that kidney function.
Rhea, this is Kent. Can you hear me?
Yeah, hi, Kent.
I don't know what happened. I'm on a hard line, so I don't know if you want me to go through.
Yeah, sure. So we can go through and share your experience. So, Jill, we'll take a pause at the Q&A session and have Kent share his experience, and then we can go back. So if you, again, have any questions, please feel free to submit in the Q&A box.
Okay. Thank you. Pretty much what I went through, basically everything that from the start to what I call finish after the stem cell transplant. Then I started with my neuropathy is what I've got. That's the worst part. Between that and fatigue, it just comes. You're going to have to deal with that. It's not very easy. You got to be patient. I am not the patient type, so it's very difficult for me. I've tried many different things, all the pharmaceutical approaches to try to diminish the neuropathy. Which has helped from the beginning. In the beginning, when I first got home from Sloan, it was very, very painful. And it was like that for almost 2 months until the pills from, basically I took Lyrica, Cymbalta, and Neurontin to try to alleviate that. I still have it. Sometimes it's not as bad as it was, but it's definitely there. You have a very difficult time in walking, stepping on, say, a rock or some small object, you're going to trip because you can't feel it. I've learned over the past few months to look down at my feet an awful lot because basically your mind isn't relating things from your feet. I do have it in my hands too, but that's pretty minimal. It's mainly in my feet. Now I have tried. I went to an acupuncturist, which a year and a half ago, if you told me I'd do that, I'd tell you were nuts. But you get to a point where you'll try just about anything to try to alleviate it. For me, it did not help, as that I could tell anyway. I had a low wave electrical impulse type treatment that I had about 8 treatments, and it just didn't seem to take. But like I say, the biggest thing is fatigue. I had problems tying my shoes, putting on socks. It would take me 20 minutes. It's just going to in the beginning. I had a very difficult time walking upstairs. I am self-employed. I've got a home office. It's up 11 steps up, upstairs, and I literally had to pull myself up the railing in order to get upstairs. That was basically back in February, March. Now I can literally just walk up, and I don't even have to. Even though I do put my hand on the railing, I'm not much better already. Still have a long way to go. They told me it would take a year, and guess what? They were right. It'll be a year, January 18th, and it just takes time. I would say I'm back probably around 80% of my energy level. One problem I have is I do work an awful lot. I'm a workaholic type thing, and my work is very physical. So it's something you got to deal with. Listen to your body. That's the biggest thing. Because if you do, then you're much better off. If you try to overdo, you're going to pay for it, and I have done that. I did start exercising. I was in a physical therapy program when I first got out for about 2 months, which helped. Again, that's going through my healing process pretty much. And then started going to a gym. I did that for about 2 months, and then I felt better to start working physically at my job. And unfortunately, I stopped exercising. I think that's a big mistake. I think exercise definitely does help. For myself, I've got to get back in the routine. If you can find some support buddy to, work out with, that helps a lot. That type of thing. Getting back into a normal routine. Just doing what you used to do. For myself, it was going out, looking at work, seeing the homeowners, contractors, and then talking about it. You would not believe how many people are touched by cancer. It's amazing. But you can learn so much from these people, too. Things that you didn't know, that you weren't told, signs, symptoms, that type of thing. Gee, I got that, that type of thing. The last thing is support is huge. Like when I was in the hospital, I would get cell phone calls from friends of mine. People would stop over after I got home, people I haven't seen in 20 years. It was amazing, and you would not believe how much that helps. So think about that when you have a friend going through it. But the support with the family, again, I'm a volunteer fireman. That is huge with our brotherhood there. People, calling you to see how you are and if you need anything. I'm still on a ski show team. We have it's very family oriented, so that's huge. Just talking to those type of people, and believe it or not, your dogs. If you have a dog or a cat, my dogs are tremendous help. They know when you're sick. They can. I feel that they can feel it, and it does make a difference. Just little things like that you would not expect. But basically, in the beginning, you can't go near them, but trying to keep them away from you. have 2 golden retrievers. It's next to impossible, but we did do it. So but that's about it. I hope it will help you people down the road here. And that's all I have.
Okay, great. Thank you, Kent.
Thank you.
Thanks for sharing your experience.
Sure.
Again, we'll move back into our Q&A session. So, okay, Jill, our next question is for you. Let's see here. Avoidance of aspirin and similar anticoagulants was recommended, but my oncologist has me taking aspirin to counteract the possibility of blood clots or thrombosis. Why the contradiction?
Absolutely excellent question, and you are 100% right. In terms of aspirin, it is absolutely prescribed, especially with Revlimid, thalidomide, and Velcade, those novel agents, because those agents in particular, some of their side effects or adverse events are clots, deep vein thrombosis, etc. So you will 100% be on an aspirin. I apologize for not being clear in that when and if your platelet counts get to a level that is very low, your physician, your providers will absolutely tell you to stop the aspirin. You should not do that on your own. You have a conversation with your team. It's very common to stop blood thinners and anticoagulants prior to a big procedure, prior to anything where you might experience some blood loss. So you're 100% right. In that scenario, you want to stay on that drug. It is of vital importance. However, just know in the back of your head, if your levels were absolutely to drop to a low point, you were to have a major procedure, something along those lines, you are on a blood thinner, and then we would stop them for a short period of time. So good point with that, and thank you for bringing that up.
I think I did.
Okay, thank you. What is an average time between transplants? Can you advise staying on maintenance instead of having transplant after chemotherapy for 6 months?
So, again, an excellent question, and I will preface 100% that this is completely related to your disease status. However, what I can say is that the research is definitive in that if you have a transplant, you want to do that transplant as close to your remission as possible, meaning you want to go into a stem cell transplant as clean and free of disease as possible, because those effects are going to give you a prolonged remission rate on the other side. Basically, for lack of very scientific language, it's garbage in, garbage out. It might not make sense intuitively, but we want to clear you of your disease and get you into as big of a remission status as we can with chemotherapy, with induction agents, with those first-line agents. And if you have a good remission, whether that be a very good partial remission or a complete response, that's when we want to, for lack of a better word, hit you with that transplant. Because remember, with a transplant, it's not the actual cells that are reinfused that are treating your disease. It's that big slug of chemotherapy that you're getting before those cells that treat the disease. So that's why transplant is really recommended quickly after we can get you into remission. Now, with that being said, transplant can be given along the continuum of your disease course. When I say that, I mean there are certain protocols that call for tandem transplants, where you get one transplant right after the other. It's very common to treat with a transplant up front, and that is standard for a number of people. You want to get that transplant in when your disease burden is low up front. But it's very common to have that, and if you relapse potentially 3 years later, you could have another transplant. It's very unlike other cancers, but that is the research behind having that transplant done very quickly after we get you into a remission. So it's absolutely a conversation you need to have with your team. It is an excellent question. It's an excellent point. You've definitely done some homework and done your reading, but have your provider give you the ins and outs of why he or she is prescribing it now at this point in time, because that will likely be what it is.
Thank you. We have another question here. Memory problems seem to be getting worse. Any suggestions? I'm 6+ years and had 1 stem cell therapy.
So with this question, first I want to validate that chemo brain is a very real phenomenon, and there is more and more being published on this phenomenon and this symptom, but unfortunately it is something that often happens exactly like you describe after treatment, progressively in later years, and it's not addressed as other more prominent symptoms are, let's say. So 100% to validate, absolutely, this is a real phenomenon. And a lot of people describe it as lack of concentration, forgetfulness, things along those lines. There are trials being done. What I would say is, speak to your provider about it. Oftentimes, if available within your hospital, might refer you to a neurologist, as we refer someone with a peripheral neuropathy or nerve damage on that end, just to kind of work that up. There are no truly effective drugs on the market right now that are being prescribed. Some physicians prescribe some B vitamins, some things along those lines, but really, unfortunately, there's nothing that's standard treatment at this point in time, but there are some kind of supportive therapies that can be done, and the neurology team is usually very, very, very aware of that.
Okay, great. Thank you. That's all the time we have today for questions. Thank you so much for submitting them and for participating in the Q&A session. So before we end, I'd like to say thank you so much for your enthusiasm and questions that have contributed to making today's webinar a great success. If you'd like more detailed information, please feel free to check out our free Frankly Speaking About Cancer Multiple Myeloma booklet, which is available to order or download on our website. And also, please feel free to visit our website or call our toll-free helpline at 1-888-793-9355 if you would like any additional information. Again, we'd like to thank our speakers, Jill Vanak and Kent Tygert, for contributing their time and sharing this important information with us. And we'd also like to thank our program supporter, Onyx Pharmaceuticals. So please take a moment to complete our post-event online survey, which you will be redirected to automatically. It is a brief survey, and we greatly appreciate any feedback that you have. Thank you for your participation.